Okay, I'm going to start the session. This is a very stimulating session on declining fertility solutions. Please settle down. I'd like to invite the chairpersons for the session on stage. The first chairperson, Professor Dr. Rashid Latif Khan, needs no introduction. As Dr. Sadiah Paul said, he is the father of gynecology in Pakistan. And as a young, aspiring gynecologist, I see no one like him in near future, unfortunately. He is the pioneer of ART program in the region. He established first IVF center in 1984. He is the past chairman of RCOG Representative Committee and the founder of CEFOG. Sir, if you would please come on stage. Thank you very much. The second chairperson for this session is Professor Sadique Jafarey, FRCOG FCPS, President of NCMNH. She's a clinician, academician, and researcher with keen interest in public health. She was previously a professor at Jinnah PGM Center, Karachi, and now a professor at Zawdin University. She has been teaching for the last 40 years. She has conducted many studies on maternal and perinatal mortality and morbidity. She has written, published, and traveled extensively. She is a member of various national and international advisory committees. Her professional contributions at the national and international level include work with RCOG, FIGO, AOFOG, and SOGP. She has received many honors and awards. If you would please kindly come on stage. It's two of you, so thank you very much. Okay, so the first speaker, Mr. John Kevin Artley. He's a consultant gynecologist at Concept Fertility Center and Day Hospital in Subiaco. His special areas of interest are investigations and treatment of male and female infertility, including surgical sperm recovery, laparoscopic surgery, pre-implantation genetic testing, reproductive endocrinology, including polycystic ovarian syndrome, fertility preservation for medical as well as social reasons. Dr. Kevin, if you would like, please come on stage. Thank you very much.
Ladies and gentlemen, first of all, I'd like to thank the organising committee for the very kind invitation to come and speak to you today and to take the opportunity to visit Pakistan for the first time and enjoy your overwhelming hospitality. The title of my talk is We've Come a Long Way in ART, and there were a number of reasons why I chose this topic or in association with the organising committee. First of all, on a personal level, 2019 marks the 30th year of my practice in assisted reproduction. I found myself fortunate to have practiced and learned alongside some of the very great people in infertility and IVF research, although I'll explain to you shortly why I was a little naive and didn't quite realise that at the time. I also think it's useful for some of the younger members of our profession to realise that what a relatively brief history assisted reproduction has in the field of medicine. I personally entered medical school only the year after Louise Brown was born, and I could no more have envisaged having a lifetime in practice in assisted reproduction at that point than we could the prospect of landing somebody on Mars. Both may happen eventually, but it seems that ART has happened a lot quicker and has become an established part of medical practice in a very, very brief period of time. And I'm also going to highlight some of my personal heroes in IVF research and practice, and some of whom you may not quite recognise, but I think deserve some recognition and have certainly laid the foundations for the modern practice of ART. So first of all, just a little bit, as our introducer has already said, I work at Concept Fertility in Perth, and that's our unit there. Looks very nice in the sunshine, and indeed it is a very pleasant place to work. So as I've already said, I'm going to just crave your indulgence for a little bit of my personal journey, highlight some of the less recognised places and people along in that journey, not just my journey, but the journey to where we all are today, and talk in itself about the journey. So this is the personal bit. I was lucky enough to get my membership at a relatively early stage, pure fluke. I happened to know the examiners, or the examiners knew my boss, and they let me through on the first time. So imagine, if you will, I'm sitting in a little, well, not a little town, quite a large town called Newcastle upon Tyne. Some of you may know it if you've worked and practiced in the UK. And to say the least, I wasn't particularly enjoying that part of my work. It was a very busy job. We were working 1 in 2, if you know what that means. So every other night we were on call, and every other weekend. And I was on the verge of giving up obs and gynae, to be honest, although I'd done quite well to that point. And my wife said, well, you can't really do that. You've worked really hard for where you are. There must be something you can do. So as you do, you flick through the British Medical Journal, the job adverts, and here was the job. MRC, Medical Research Council, funded research fellow in IVF. Experience not essential. Research towards an MD will be supported. Based in Cambridge. Now, in my naivety, I had not a clue what Cambridge meant to ART. I knew it was a very prestigious university. I thought I had about a 1 in 200 chance of getting the job, but at least if I got an interview, it would be a day out from work. However, as it happened, I did get offered the job, and realizing that there may be something special going on here, I took it. And the first place I want to highlight that not many people think about, but I can assure you that this floor here is probably the single reason why we're all here today. This is the Marshall Laboratory of Embryology. This was the laboratory where Professor Robert Edwards did his work, alongside numerous research students and other people that were involved. And guess what? This is where I did my work. But I didn't realize that at the time. It was just a pretty ugly looking building. This is the team I joined. I just want to highlight 1 or 2 people. This is a chap called Peter Brodie, who was my immediate boss. He was the senior lecturer, went on to be professor at St. Thomas's. Some of you may know him. He's written too many articles to imagine, and was part of very basic medical research into embryology and assisted reproduction. Some of you who have been in England recently, or practiced in England recently, or have anything to do with the Royal College may recognise this person. This is the outgoing president of the Royal College of the Obstetricians and Gynecologists. At the time, she was a senior registrar. That was Leslie Regan, now Professor Leslie Regan, who is widely published in the field of recurrent miscarriage. I also just want to highlight this gentleman here, because he's going to come up later in the story. I won't labour the point now, but he's a very important person, both in my life and in everybody's. And there's this little chap here. I'm not sure who that was, but it looks like my younger son. So we can hardly talk about the history of assisted reproduction without talking about Bob Edwards, Professor Robert Jeffrey Edwards. It's interesting to note that when you go back to some of his original publications and you talk to people who knew him back then, and I was fortunate enough to meet him on several occasions, his main interest was in the genetics of embryos and embryology. That was his main work. DNA had only just been characterized and was able to be looked at the point at which he was looking at embryology, and he was interested in the DNA and chromosomal makeup of embryos. And that was his main thrust of his work. He wanted to know what was going on with chromosomes in early development. He moved around various places, Edinburgh, Northern London, working in a number of embryology laboratories, mainly animal embryology, obviously, because at that time human embryology was to say the least, in its infancy. But he eventually ended up as the Ford Foundation Research Fellow of Embryology in 1963 in Cambridge, which is where he carried on and did the bulk of his human embryology work eventually. The chap he's talking to here is the next subject of my story, and he's called Colin, otherwise known as Bunny, Austin. A little bit of uncertainty as to why he was called Bunny. One of the ideas was that he did a lot of work on rabbit embryo research. The other possibility was that there was another well-known tennis player around at the time who was also known as Bunny Austin. So he got that name by default. But Bunny is a very, very important person. Bunny was the head of the laboratory, of the Marshall Laboratory, when Bob Edwards was appointed to the Ford Research Fellow position. He was the first Charles Darwin Professor of Animal Embryology. He was the person who recognized, and I was interested to hear it come up in one of the talks earlier about male problems, he was one of the first people to recognize that sperm, in order to fertilize eggs, needed to undergo capacitation. And he proved that in an animal model. But his main role was as a haven, a supporter, a very vociferous supporter of Robert Edwards, particularly when things were starting to get pretty hot in the human world, and I'll explain a little bit more about that later. And Bunny was an unswerving supporter of Bob's work, provided a haven for him, and allowed him to carry on and do his work. And had that not been possible, then again, history could have been very different. Patrick Steptoe, I guess we've all heard about as well. And this is where serendipity comes in, as it does in many areas of research, breakthroughs, and practice. By all accounts, Patrick was not an easy person to work with, as most pioneers are or are not. And it's often said that one of the reasons he ended up being in a relatively non-glamorous part of the world, namely Oldham District General Hospital, which as a Brit I can assure you, if you've never been there, is not the nicest place in the world. But one of the reasons was it was the only place where he could work and be alone and not upset anybody else. Now, interestingly, if you go back to articles that have been written about Bob and Patrick meeting up, they can't agree. In later life, neither of them actually agreed when they first met. There was something about they met at a Royal College a Royal Society meeting. Something says that Bob had read a paper that Patrick had written about laparoscopy, because Patrick's main role was as one of the early pioneers and adopters of laparoscopic surgery, certainly in the UK. And it's said that Bob Edwards saw the possibilities there of gaining access to human material. However, when you spoke to Bob, actually what he was trying to do, the first thing he was going to do, was actually to get sperm that had been capacitated in the female genital tract. And so his first approach to Patrick was not to get eggs, which everybody seems to think it was, although that was a very happy circumstance, but it was actually, Bob couldn't work out how to get sperm capacitated. They spent 2 years trying to do that, just trying to get sperm to be able to fertilize eggs. And that was the reason why Patrick was first approached. This guy, not many people, I think, have heard of, but Barry was a key figure, because just going back to the point of capacitation of sperm, Barry solved the problem. And Barry worked out, he just decided he'd play around with culture medium. And he gradually changed the pH of the culture medium that the sperm were kept in. And lo and behold, he found that by raising the pH, you capacitated sperm. And they did that in humans, with human sperm, and it worked. But one of the things that, again, is very easily forgotten is that on the fateful night when they'd managed to capacitate sperm, they'd managed to get a human oocyte, and they'd put them together, the first person who witnessed the first human egg being fertilized in vitro was Barry. Because Bob couldn't bear to look again, because he'd looked at so many that had failed, he just couldn't face it. So he made his research student do it instead. Barry went on to develop some of the earlier other culture mediums we used. And if you look back at the early work of embryology, and Bavister's medium is one of the very widely used ones. But things have obviously moved on. So here's some of the science. And as I've already said, some of the very simple, basic steps took so long to work out. The dedication and the persistence of these early guys cannot be overestimated. You know, the likes of you or I, certainly I, would probably have given up years before. But they were scientists. They wanted to solve problems. So they just kept going. And this is some of the early, this was the early work that Bob published with human oocytes, published in 1969. And look at the numbers. They got some eggs, 56, controls to prove that, you know, there wasn't a fluke going on. 54 survived, matured. Look at the number. They got to 2 pronuclei. 2 out of 56. And this was worthy of publication. But imagine how that, I mean, it must have felt great, but on the other hand, looking back on it, how did they have the courage to carry on? Incredible. Well, the courage to carry on took some testing, because having achieved what they thought was something magnificent here, and of course it was, with hindsight, they thought they'd apply for an MRC, Medical Research Council grant. Again, for those of you who don't know, the MRC grant is the sort of recognition, it's the bedrock of having a good research program. You get funding, it's government-approved funding, so it's recognition. But the comments that basically Bob's application to carry on with this human embryo work got rejected out of hand, and this is one of the comments. I'll let you read for yourself. In these days when science seems to happen through the newspapers, through Google, through whatever else, the idea going back there, you know, he needs to publicise his work in radio and television. I think there've been 1 or 2 newspaper articles published, hardly anything. So Bob felt pretty bruised about that, it has to be said, and the whole thing shut down more or less for a year while he reflected and took views and decided what he was going to do. And was it not for the fact that he got a lot of support from people who trusted him and his own doggedness? He was a very dogged character, very clear thinking, but very, very, very pleasant, very easygoing. But he knew what he was doing, and he had, you know, he had grit. Now, this is another person which some of you may or may not know about, and I think it's quite relevant to some of the discussion you're having here at the moment about where does IVF fit in with local law, regulations, tradition, religion, and so on. We had the same debate. There were real vociferous gut reactions to IVF in the UK. You know, meddling with nature, you're playing God, you're going to create Frankenstein babies, you're opening Pandora's box, it's going to lead to all sorts of issues. Well, some of that was true, it has led to a lot of issues. But we were fortunate. The government took a fairly sort of even hand in it and said, okay, we need to allow for educated debate on this. And they were so lucky in appointing this lady, Dame Mary Warnock. She was a philosopher. She'd published numerous articles on philosophy. And at the time, she was mistress of Girton College, Cambridge. And she headed up the Committee of Inquiry into Human Fertilisation and Embryology, which sat for 3 years between 1982 and 84. And as government committees in the UK do, she took representations from anybody who wanted to come forward. Scientists, religious groups, individuals, self-help groups, although those were not a big phenomenon back in those days. And again, I met her on a couple of occasions because at the time, we were an MRC-funded embryology research unit, and so she used to come and visit us for advice about some of the science and so on. Again, a very unassuming lady, very, very simple, very straightforward, but an intellect, very, very clever, probably one of the cleverest people I've ever met. And it was the trust that the public and the government placed in her and her committee that meant that when she came out with recommendations, which were very, very balanced and very even, fortunately saying, you know, this is technology that's going to help people in the future. Research should be allowed. We need to do research because we need to improve the technique. We need to see what it can hold. So that's what the report essentially said, but under strict guidance and controls. So that led to the formation of what was called the Voluntary Licensing Authority initially, so that there was something immediate happened there. So all of the clinics, bar one, signed up to that. And then eventually a government act was passed called the Human Fertilisation and Embryology Act, which still stands to this day with amendments as technology has moved on. They looked at PGS. They're currently looking at the 3-parent baby thing, the mitochondrial transfer, cytoplasmic transfer. But it's a statutory body. It licenses clinics. It makes sure certain standards are in place. The reassurance that this gave the public in general, not all of it, obviously, there will always be opponents, but the general reassurance was what allowed us to move forward. It allowed us to carry on working, develop techniques, get better, and has allowed us to be where we are today. And I'm not being Anglo-centric here, but a lot of the regulatory bodies that exist around the world have copied the Human Fertilisation and Embryology Authority, or at least copied large portions of their structure and the way that they work. Some would argue not for the best, but in a world where public need reassurance, it is important that we offer them that reassurance about what we're doing and that we are adhering to certain standards of practice. A couple of other milestones, of course, ICSI. I worked in the early days when, if you had severe male problems, and with due respect to my fellow speaker earlier, if you had severely low sperm count, that was it, curtains. You might have sperm, but there was nothing we could do about it. We had this concept of the delicate egg, as I put it. The egg, you couldn't do anything too manipulative with the egg. It would fall apart. It wouldn't work. So we came up with these kind of interim steps. Some of you may recognize those. SUSI, subzonal sperm injection. So you injected the sperm beneath the zona, but didn't touch the egg. Couldn't touch the egg. Or partial zona dissection. There were, I think, reports of the odd pregnancy happening there, but the rates were abysmally low. Until it was that Jafarey came up with ICSI. And guess what? The rougher you seem to be with the egg, the better it works. You just bang the sperm in, and if you bang it in better and suck up half the cytoplasm with it, you get better fertilization rates. Who'd have thought? But we've got to accept that was a real breakthrough, a real milestone, completely changed the landscape as far as how we manage fertility, particularly male, obviously. PGD, PGS, very hot topic at the moment, certainly PGS, pre-implantation genetic screening, but obviously started off with pre-implantation genetic diagnosis, and Alan Handyside published his paper in Nature in 1990, using fish for fluorescent in situ hybridization to simply sex an embryo. And they were trying to help with sex-linked disorders, and they published that data and the first data on the first pregnancy. Was it a new dawn? Well, certainly it's opened the door to a lot of other things going on, and one of our speakers later is going to talk a little bit more about pre-implantation screening and the various techniques. And so that technology has raced ahead. But I would ask you just to think very carefully, and say due respect to my later speaker, is it going to offer everything it seems to promise? It's a wonderful technique. It offers a lot of information, but how beneficial is it in reality? I think we just need to think about that a little bit. But what I'd also say is the PGD, PGS, Alan publishing his paper on pre-implantation genetic screening, looking at the genetics of embryos, marked the completion of the circle, because that's where Bob had started. Bob had started with the idea that he was going to look at the genetics of embryos. IVF and helping people with fertility was almost a sideline, a very important one, but almost a sideline. Alan's work went back to saying, yes, this is how we're going to look at the genetics of embryos, and this is how we're going to use it to help people. And Alan indeed was one of Bob's second cohort of PhD students. He'd actually worked with Bob in his laboratory when Bob was doing his work. But one of Bob's first PhD students, in fact, one of the first PhD students, alongside Sir Robert Gardner, who is a Professor of Embryology in Oxford, or Emeritus Professor of Embryology in Oxford, was this chap. And if you remember, he's the one I highlighted back in the slide, way back at the beginning. And this is Professor Martin Johnson, who, as I said, worked alongside Robert Gardner as Bob's first two PhD students. And rather like Bob, Martin is one of the most unassuming characters you could possibly imagine. He was my coordinator on my MD thesis. He will explain things to you in the simplest ways. He's just a very, very nice chap, but immensely clever. He's here with Bob's wife, sadly now widow, Ruth Fowler, or Ruth Fowler Edwards. Ruth was actually a very, very good scientist in her own right. She met Bob in Edinburgh when they were working in the lab there. And what they're doing here is they're accepting Bob's Nobel Prize for science. Bob, unfortunately, although he's alive at the time, was too unwell to attend the ceremony in Stockholm where the Nobel Prizes are awarded. And he asked Martin to go along with his wife and accept the prize on his behalf. And I think that marked the arrival, albeit a little bit late in the day, and the acceptance of what Bob had done and where we are now. And for me, it sort of made me think, goodness me, how lucky was I to have worked with these people. I'd like to acknowledge Martin's help. He provided a lot of access to a lot of his papers while I was preparing this talk. I know it's not very detailed, but it was very useful for me to clarify my mind and to get things in the right order. And in turn, obviously, all the people that have helped and worked with Martin. Thank you very much.
Thank you very much for taking us through this journey and talking about the giants of IVF. Our next speaker, Dr. Graeme Thompson, is a consultant obstetrician and gynecologist and specialist in assisted reproductive therapies at Concept Perth. He is also a clinical lecturer in reproductive medicine at the University of Western Australia. His major interests are ART and infertility surgery, with emphasis on laser laparoscopy, microsurgery, which is a dying art, ectopic pregnancy, Asherman syndrome, and endometriosis. If you would please come on stage.
Thank you. I'll try not to trip. Thank you, Maria. I'd like to echo Kevin's words and thank the organisers for inviting us here, to thank you for coming and in such large numbers, and to thank the people of Pakistan for being as friendly and accepting as they are. I'd like to not thank the rain gods of Karachi who rained out the cricket yesterday. I'm going to talk about evidence-based IVF treatments. And I'm going to be quite brief in a lot of the areas, and I trust you'll bear with me. I'd like to start, you've seen this one, but this is the mothership, and that's just me. It's a shame I don't get any money from anybody. Okay, the thing that brought me to this talk was the fact of what's happened with the technique of endometrial scratching or endometrial biopsy. We all have had in the past patients come to us with stories that they had a friend who had a DNC and they got pregnant in the next cycle, and we thought, yeah, well, that doesn't really work. And then people tried to see if there was any basis to these beliefs. And lo and behold, the outcome was that there was some benefit, it seems, and then it became more serious. Cochrane is oft quoted, and the initial Cochrane review showed that there was benefit in cycles of timed intercourse and intrauterine insemination. They went on from that to subsequently in 2013 look at the benefits or otherwise in reproductive technology cycles and found that there was. And in fact, there was an increasing ongoing pregnancy and live birth rate in that Cochrane review, and with odds ratio of 1.42, which is a pretty acceptable odds ratio, really. So we all thought, right, we've got a basis for what we want to do and what we are doing, and we all took it up big time. So basically, Cochrane said that there was evidence that endometrial injury resulted in an inflammatory, perhaps, process which then aided implantation in the subsequent cycle. The evidence was of ongoing clinical pregnancy and live birth rate of moderate quality, but there was low quality for any of the other outcomes. But what we're interested as a group is in live birth, and so that was good for us, we thought. And then this year, somebody from the Netherlands threw a spanner in the works. And I've talked about Ben Mollerdale because Ben Moll is now in Australia, but it was a group from the Netherlands, from Amsterdam, that did a multi-center global randomized controlled trial with high patient load. The only thing that they couldn't do was double-blind it, but that's obvious. And so they looked at a large number of patients, 1,300 odd. So they underwent randomization to either having an endometrial trauma with a papillary biopsy, which was described before, or to no treatment at all. And the qualification for going into this trial was that the patient had not had any sort of invasive technique, including hysteroscopy, in the recent times. Boom. Odds ratio, 1. In other words, the live birth rate, which was their outcome, was the same in the control group, exactly the same in the treatment group, which really rained on our parade. We had a technique which we thought was working, which was evidence-based, and then somebody goes and scuttles the ship, so to speak. I'm going to briefly talk about the other things that we throw at patients in profusion, but not dwell too long on any of them. I apologize if you don't have time to get the references, but if you wish, I can always give them to you. Okay, the first is CoQ10. It's an antioxidant. It has an involvement in mitochondrial energy production, reducing oxidative stress, and we wondered if there was an input into either male or female infertility. In male infertility, there's no evidence that it increases live birth in males, that CoQ10 does, but it does increase the parameters in sperm, in all sperm parameters. CoQ10 in female infertility is not supported a great deal by the evidence in the literature. Basically, this group is known in Australia because the person at the end is Roger Hart and he's a Perth resident. But basically there was no evidence that there was support for an improvement in live birth rate in females treated with CoQ10. Melatonin is good if you're sleep deprived, I'm told, but it's another antioxidant, and it's supposed to reduce oxidative stress and improve outcomes, but it doesn't really. All of the studies on melatonin are of poor quality and show no improvements in pregnancy rates or live birth rates. DHEA and testosterone, which are androgens basically, have got some evidence. In women identified as poor responders, DHEA pre-treatment has been associated with improvement in birth rates. The overall evidence is moderate. Both of these studies showed that DHEA supplement improves IVF outcomes in poor responders, but remember that the definition of poor responders varies from study to study, regarding who you look at, basically. What they were saying was that in poor responders, that you could get more oocytes at retrieval, but it doesn't really relate to live birth rates. Growth hormone. Growth hormone, even in Australia, is exceedingly expensive. It's been shown to improve live birth rates in some studies, and it's got a p-value which is significant in these studies. However, the p-value is small, and it's based on 3 very small studies, and so a questionable response outcome. And if looking at the economics of it, for us in Australia, it's not economic, and I imagine the same would occur here. So meta-analysis did show a benefit in growth hormone with a greater number of oocytes, same as DHA, and an improvement in many of the clinical outcomes, but there is no evidence of increased rates of live birth. And I'm just draw us back to the fact that that's really the outcome that we're looking for. I'll leave that with you, you could read it too. Aspirin and Clexane are both going to affect blood clotting and are thought to be maybe useful in patients with thrombophilias. Thrombophilia, for the number of times that we actually check the vast array of tests that we do for thrombophilias, is not common. They are not common outcomes. And heparin's more powerful than aspirin and does promote bleeding, and as I said on the slide, embryos do not like bleeding. This is where it gets a bit tricky. Immunomodulators, and I've grouped them there, glucocorticoids, intravenous gamma globulin, etc. They are potentially dangerous to both the patients and the embryos. And the study that I've quoted there shows no role for immunotherapy of any use. Even if you look at glucocorticoids, the problems associated with them, you've got problems in the maternal side of the thing with even outcomes like increased risk of diabetes, but you've got problems in the fetus as well with increased risk of cleft palate and other outcomes. Everyone's talking about pre-implantation genetic screening, aren't they? It was going to be God's gift to Whippen. The idea was that we're going to only transfer chromosomally normal embryos, and these embryos, chromosomally abnormal embryos, are associated with a higher risk of miscarriage, and we all know that. It was supposed to obviate those treatment cycles that were doomed to failure because of chromosomally or aneuploid embryos, and it was supposed to increase the chance of live birth. PGS1, which is what you do here, I believe, which is blastomere biopsy, did seem to be encouraging, and then we moved to trophectoderm biopsy, which is PGS2, which was thought to be less invasive because you're biopsying the trophectoderm and not interfering with what's going to become the fetus as much. With blastomere biopsy, these were the results from concept back then. It did improve the pregnancy rates. You can see there are IVF results, FET results, and then those results that we got with transferring PGS embryos. And obviously those are frozen embryos, most of the time. Those figures are after one complete cycle, the pregnancy rates associated with those age groups. And for over 40 years, for patients over 40 years old, that looked very encouraging because these were the patients that were supposed to benefit. And to get a 10% pregnancy rate in patients over 40 is quite good, I think. But then that's my demographic. Unfortunately, with trophectoderm biopsy, those things are true. Initially, before we went to all that things, the initial study by Mastenbroek in 2007 showed that it did not increase, but significantly reduced the live birth rates in women of advanced maternal age, despite what I said with my last slide. And then more recently, although initially it appeared to increase the chance of success, the per cycle started, the chance of success was in fact reduced. There are a couple of units around the world who have looked critically at the outcomes with PGS and have shown that if you take what is supposed to be tested aneuploid embryo and put it back, you can get normal babies, which is pretty radical, and it takes a brave person to say to a patient, look, we've got this, we don't believe that it's abnormal completely, it's a mosaic, and there's good cell lines and bad cell lines, and so we're going to put it back and see what happens. But Greco did, and found that he got babies that were normal to term. Also, the other big proponent currently in the world of doing this is Norbert Gleischer, who's a very colourful fellow from the States. His taste in suits leaves a bit to be desired, but still, I should have a photo of him. Anyway, he did the same thing and got those results from chromosomally abnormal babies. Those are some with fetuses, sorry, and got normal births. So Gleischer concluded that the increasing evidence suggests that PGS2, that is trophectoderm biopsy, is at least in unfavourable patients, those populations who are considered the best candidates, that is aged patients, actually reduce pregnancy rates and reduce live birth rates. I'd like to end on natural killer cells, and I don't know whether there's much interest in natural killer cells in Pakistan, but it was thought that these macrophages would be in the uterus and would attack the developing fetus and therefore result in early pregnancy loss. In Australia, the major proponent is a chap called Gavin Sachs, who happens to come from Bondi and has presented the Bondi Protocol, which is really an offshoot from the Colorado Protocol. There are controversies about this, though, and that is, what is the real role of uterine natural killer cells? How do we test for uterine natural killer cells? And the treatment. Testing for natural killer cells, this comment is incisive, I think, in that HFEA, I think it was from it is, said that testing peripheral blood for uterine natural killer cells is about as useful as tossing a coin. Testing of uterine natural killer cells directly, sorry, I'll go backwards, Sorry about that. But I'll leave that up there anyway. But the testing for uterine natural killer cells means doing an endometrial biopsy, and the uterine natural killer cells are different at different stages of the cycles, and they seem to have a role which is not to destroy developing embryos. The Bondi protocol that he puts forward is prednisolone and clexane. And prednisolone has its own problems, as I pointed out before, as does clexane possibly. That was the protocol, still is from his point of view. Now, it seems really that the normal role of natural killer cells is important, and is important in pregnancy as well. And patients who took drugs as were proposed of prednisolone and clexane had higher rates of congenital abnormality and sorry, I've lost it, higher rates of preterm birth as well. I like quoting the old Latin because in the old days we did Latin at school. Primum non nocere means first do no harm, but we all know that. As I put forward before, the fetal studies showed that it doubled the chances of preterm birth, tripled the risk of cleft palate, with a fetal anomaly rate of 4.6%. In the mother, use of the drugs encouraged gastric ulceration, diabetes, Cushing's syndrome, hyperlipidemia, etc. One of the conclusions is that the evidence for some or many of the therapies that we use and our colleagues use is sometimes minimal and sometimes not existent. And unfortunately, we deal with a population of patients who are very, very vulnerable, and will be pointed out a number of times that if you told them that if they walk upside down on their hands for a week, it will help their pregnancy rate, they would do it. What we should be doing is giving our patients good advice based on evidence and letting them make their own decisions and not encouraging them to do things that we don't actually believe in or in which we don't actually believe. I put the lower one in about if they seek a second opinion because that was what happens in Australia. If you don't give the patient what they want, they'll go take a walk to a different clinic. They have access to internet, as do your patients, I believe, and the internet is rife with all sorts of magical treatments, balms and whatever else, that say that this will increase your pregnancy rate, and the patients will do it. And you can talk yourself blue in the face and they'll still do it or still want to do it. Thank you for your attention. Take care.
Thank you very much for such an updated, enlightening talk, and I'm sure this talk must have stimulated some questions, and I'll start with myself. So the first question I'm going to ask is, although that RCT that you have quoted had refuted the role of endometrial scratching, but what has been your clinical experience? Why does it seem that it works?
That's really not fair. Having just had this discussion outside with Maria, I have problems with the study from the Netherlands, and I don't know what the numbers were that had their scratching done in the menstrual part of the cycle in which the transfer was done, and I believe that that would be useless. And also the study doesn't tell me how many were done in the menstrual phase of the cycle prior to the one in which the embryo transfer was done, because I think that would be equally useless. Unfortunately, I have to confess to still being a believer, but believe that I should tell my patients that the data from the Amsterdam study is there, and it's their decision what they want to do.
Thank you very much, and I must apologize for my naivety. I didn't know this is a plenary session, that we are not allowed to ask questions. So
You're
sorry
allowed.
about that.
Are
We'll
there
do
any other
that
questions?
later. Thank you very much.
Thank you.
Our next speaker, Dr. Souraya Jaroudi, is a molecular geneticist experienced in reproductive genetics and molecular diagnostic and a certified high complexity laboratory director by the American Board of Bioanalysis. She designed and helped set up for Alan Fertility. She founded the Genetic Project Studies and Consulting, GPSC, SAL. Currently, she is a consultant for Cooper Genomics. She has published multiple peer-reviewed papers and book chapters in the field of reproductive genetics. Please come up on stage. Thank you very much.
Is that all right? Yeah. Thank you for the introduction. Before I begin my talk, I'd like to start by thanking Concept Fertility Center for the opportunity to come to Pakistan. It's my first time in Pakistan and present at this at the first International Fertility Conference. As my title suggests, I will be talking about genetic testing for the improvement of ART prognosis, and specifically focusing on pre-implantation genetic testing for aneuploidies and endometrial receptivity testing. For full disclosure, I work for Cooper Surgical as a consultant, and we provide genomic testing service. Pre-implantation genetic testing for aneuploidy, or previously referred to as PGS, aims to improve the outcomes of IVF by selecting the embryos that are known to have a chromosomally normal makeup and preferentially transfer those embryos. So the theory behind it is by identifying embryos that have the incorrect number of chromosomes and are more likely to fail to implant or lead to a miscarriage, we can preferentially transfer the embryos that are chromosomally normal and more likely to result in implantation and ongoing pregnancy. The history of Pgt Ai, this has been touched on briefly with the earlier speakers. So it started with fish in 1993, and this was blastomy or single cell testing from the cleavage stage embryo. And there's been many improvements and developments within the technology used with RACGH and then next generation sequencing most recently. NGS gives the highest resolution of analysis. It has the greatest data points and allows us to do comprehensive chromosome screening in a very accurate way. With the transition with technology, the embryo biopsy stage has also moved on from day 3 to day 5, or blastocyst biopsies, and having several cells for analysis from the blastocyst biopsy, and this is when a trophectoderm biopsy is taken. Those few cells allow us to detect mosaicism, which was something that could not be detected when analyzing just a single cell. Most recently, that's almost exactly a year ago now, in early November 2018, Cooper Genomics launched Pgt Ai, which is our own analysis platform for Pgt Ai, and it really has increased the accuracy of testing by quite a big jump on top of NGS, which has been the most accurate technique available to date. So most of you are probably familiar with this. Very briefly, the Pgt Ai process involves in vitro fertilization to create the embryos, of course, and ICSI is not required for Pgt Ai. This is then followed by embryo biopsy, and the preferred stage of biopsy is blastocyst stage biopsy for Pgt Ai. At that stage, a few cells from the trophectoderm layer are taken, and this is done by keeping away from the inner cell mass. Embryos at the blastocyst stage are known to be more competent and more resilient to biopsy. And the additional cells, of course, allow us for more accurate genetic analysis and allow the detection of mosaicism as well. Vitrification is necessary when performing blastocyst analysis to allow for enough time for the laboratory to perform the Pgt Ai analysis. Once results are ready, they're communicated to the IVF centers, and the suitable embryos can be transferred. Using next-generation sequencing, it is possible to detect aneuploidies, so those are whole chromosome gains or losses. Segmental aneuploidies, that's a partial gain or loss of a chromosome, so when only one arm of a chromosome is gained or lost. Unbalanced translocations that are similar to segmental aneuploidy. And polyploidies, more specifically male triploidies. This is when you have three copies of the genome rather than 2 copies. Every cell should have 2 copies of every chromosome, 1 inherited from each parent. Occasionally, you could have, at fertilization, you could result in, abnormal fertilization could result in a haploid embryo or a triploid embryo when you have a whole extra set or a missing set of chromosomes. So male triploidy can be detected with NGS. However, female triploidy, because that's 3 exact copies of all the chromosomes, is undetectable. It looks, when normalized, it looks exactly like 2 copies. And haploidy also cannot be detected. With a trifectoderm biopsy and the high resolution of NGS, it is also possible to detect mosaicism. So this is how Cooper Genomics categorize our results. This is how they're reported. A euploid result is when the sample contains normal cells. All the cells are chromosomally normal. It is categorized as aneuploid if all the cells contain the same chromosomal abnormality. And you could have a result that's in between. The embryo may have some normal cells and some abnormal cells, and if this is picked up in the biopsy, then it is possible to detect mosaicism. We have a very high resolution assay enabling us to detect mosaicism from 20% to 80%. And the limitation is really because of if we're considering the biopsy containing 5 cells, then you can have at least 1 out of 5 cells, and that's the 20% detection. And at the higher end, if it's 4 out of those 5 cells, of course, you could have anything in between as the number of cells vary. Several studies have shown that mosaic embryos are less likely to implant, more likely to miscarry, but they can result in a live birth. And this is why we report mosaicism separately from full aneuploidy, as those embryos may be considered for research. And I'd like to, for transfer. And I'd like to touch on some of the studies that have been shown by Graeme earlier. And just mentioned, Gleicher is very known to be against Pgt Ai, but in his study and the recent study he's published, which was more of a survey showing a much larger number of embryos transferred that were categorized as abnormal, resulting in live births. They're grouping mosaicism along with aneuploidy. There's no distinction there. And this is a big difference. We're seeing, so what's happening nowadays when there's worry about transferring mosaicism, and Cooper Genomics offers genetic counseling to assist doctors with this stage. But of course, euploid embryos are preferentially transferred, and this is followed by the consideration of mosaic embryos when there's no euploid embryos for transfer. So it just gives patients more options. The main indications for Pgt Ai have been historically, it's advanced maternal age, recurrent pregnancy loss, previous IVF failure, more recently male factor, severe male factor, but we're seeing more and more single embryo, good prognosis patients opting for Pgt Ai in order to have more confident single embryo transfer and just improve their chances of getting a successful pregnancy from their first IVF cycle. Aneuploidy affects patients of all ages, but it is shown to increase with maternal age. So you can see in blue aneuploidy increasing quite steadily with maternal age. However, even in younger patients, a good proportion of embryos are abnormal, they're chromosomally abnormal. So Pgt Ai is suitable or could help patients of all ages. I'd like to also point out here mosaicism rates. It looks like they're declining a little bit with maternal age. Mosaicism is not affected by maternal age at all. It's, the decline here is more a result of increasing aneuploidy that we're seeing with advanced maternal age. There are several studies, including randomized control trials, that have shown actually the only randomized control trial that has shown negative effect or no effect of Pgt Ai has been Matzenbrook's study. And it's a study from 2007 looking at day 3 embryos and utilizing FISH, which is a technique that allows the analysis of a limited number of chromosomes. Several other studies have been able to show, in addition to the mitigation of the effect of maternal age and increase in live birth rates per embryo transfer, a reduction in miscarriage rates, and reduction in time to pregnancy, which are very important benefits that are often dismissed in arguments against Pgt Ai. This is the SART data, which is the Society for Assisted Reproductive Technology in the US. And it includes hundreds of thousands of cycles, so it's really very large data. You can clearly see with Pgt Ai shown in green here that the miscarriage rates are reduced with the use of Pgt Ai, and also that the effect of maternal age on miscarriage is mitigated with the use of Pgt Ai. And in each patient group here, you have the samples are in the tens of thousands. This is incredibly large data. So despite it being not a randomized control trial, it is very statistically significant, and it shows very clear benefits of Pgt Ai. And it's part of the reason why it's adopted so highly in the US. This chart over here on the right shows, again, the effects of Pgt Ai on live birth rates, increasing live birth rates, especially in patients of advanced maternal age. Of course, I have to note here that these are live birth rates per embryo transfer. And as patients get older, I appreciate that it is harder and harder to find a euploid embryo to transfer. So a lot of patients may not have a transfer. Cooper Genomics launched Pgt Ai, which is our analysis platform for Pgt Ai, in November 2018. The point behind this was to develop our own statistically robust and accurate analysis method for Pgt Ai, because despite the very high resolution and incredible technology we have with NGS, we still saw limitations. And the software was built using embryo biopsy data from over 1,000 embryos that were known to be euploid. So those embryos had resulted in live births or a sustained pregnancy and were confirmed euploid following testing with a conventional NGS analysis. This algorithm was then validated using sequencing data from over 12,000 embryos, and those were reviewed one by one using both techniques. And just to put things into perspective, the previous software we were using, which had been designed in 2013 and not updated since, but all laboratories worldwide, this is what you use when you buy your sequencing equipment. It was validated on tens or up to 100 samples. So the magnitude of improvement in the validation of the technology here is huge. It's at least twofold. So this is how we were analyzing prior to Pgt Ai. The data generated by NGS is smoothed by the software in order to create those analysis profiles, NGS profiles, that the laboratory scientists would interpret and then transcribe a report that is sent to the clinic. This part here can be quite subjective and is prone to human error, despite having very stringent protocols and very experienced people analyzing. And I'll show a few profiles just to give you an idea why that can be. With the use of AI, this whole process is automated. So from the time the data is generated by the sequencer, The analysis, without needing to smooth the data and remove any data points, all of the big data utilizing artificial intelligence and machine learning is being used to interpret the result and automatically generate that report, removing all subjectivity and any room for human error in that process. So just to illustrate the idea a little bit, this is a very nice, clean profile. I purposely chose this. The midline here is when you have 2 copies of a chromosome, and if it crosses the red line, you're looking at a monosomy or a loss of a chromosome. If it crosses the green line, you're looking at a triploidy. Something in between here, we would consider a mosaic sample. So that's a mixture. One cell would have had the monosomy, but the other cells would be normal. And this is why the shift is not so severe or not so clear. So sometimes you're not sure whether to call this or not to call this for a mosaic. Do you want to deprive the patient the chance of having this embryo transferred? With AI, this was called as mosaic. So we can confidently call this mosaic. Now, whether or not this embryo should be transferred is a different discussion. But the accurate interpretation here would have been that this is a mosaicism for chromosome 6. Another example of a slightly noisier profile and quite difficult to interpret, which shifts would you call and which ones wouldn't? If you notice here, we're looking at chromosomes 21 and 22, or 20 and 21, but including chromosome 21, that's a scary one as well. And what do you call, what do you not call? In this instance, the AI, by overlaying that profile against all the references and utilizing all the data point, it can, using highly statistical accuracy, give us a confident result and call this euploid. So since its application in our laboratories from November 1st, 2018, through to May, so that's about 7 months, end of May, 7 months worth of data, we have seen more euploids reported, more confidence in embryo transfer, and more patients who have had at least 1 euploid embryo available for transfer. And this has been mainly due to the reduction, and that's a relative decrease, 21.2% relative decrease in mosaic embryo reporting. It was also resulted in an increase in approximately 8% increase in euploid embryo reporting, and a decrease, but a lower one, in aneuploidy embryo reporting. The net change specifically overall was about 6% increase across all age groups, 6% increase in euploid embryos reported, and 4% decrease in mosaics. This varies, but you can see that across all age groups, there was an increase in the proportion of euploid embryos reported. And the same was observed if we look at the patients who had at least 1 euploid embryo available for transfer. Across all age groups, and this was very statistically significant, we saw approximately 4% increase in patients who had at least 1 euploid embryo available for transfer. And they're not huge numbers, huge percentages, but these are very valuable increases for patients of maternal age. So we want to find every euploid and give that embryo a chance to implant. Most recently, in early September, actually on the 1st of September this month, we launched Pgt Ai 2.0. That's our new iteration or new version of the software. And we've worked hard to make that analysis even more robust and this is now possible by having 2 independent methods of analysis. Paired end sequencing has been introduced rather than single end sequencing, and this is what corresponds to the NGS type of analysis, the sequencing that was happening previously, but now we're getting at least double the data from just that method. In addition to this, SNP coverage. So that's SNPs are single nucleotide polymorphisms or normal changes that are spread all over the human genome. We all carry millions of SNPs. Utilizing many SNPs together allow us to do a form of fingerprinting and also accurately counting chromosomes. So those two methods together give for a much more accurate analysis for aneuploidy. In addition to this, with the use of SNPs, we are now able to detect haploidy and female triploidy, which were previously non-detectable. It's also possible to confirm 2PN. And if desired, with the use of SNPs, and if we have parental DNAs, it is possible to identify the parent of origin for the specific abnormality. So the reason this is important, triploidies affect about 3% of embryos, and about 15% of all first trimester miscarriages with confirmed aneuploidy result from polyploidy. We were missing a significant part of this when we couldn't detect female triploids. Haploidy is also important, but embryos that are haploid would not implant, so it's useful to detect haploidy in order to improve IVF outcomes. And the 2PN check verification is also possible, as we're able to detect haploidy now. Not all whole chromosome gains or losses that are of meiotic origin come from the egg. The majority do, and that's about 90% of the time. However, that leaves 10% of the time when those errors are inherited from the father. Meiotic segmental aneuploidy is also most often of paternal origin in 70% of the cases. So identifying the parent of origin when looking at aneuploid embryos could help enable more confident donor gamete decisions, because a lot of the time we blame the egg automatically, and when patients have multiple failed attempts or all embryos are found aneuploid after more than one cycle, they may consider egg donation. And in some cases, sperm donation may be more suitable. It can also just help provide peace of mind to understand why that is and why they're having such difficulties conceiving. So just to summarize, with Pgt Ai 2.0, we're combining two independent methods of analysis, which is the first time we do this with PGT, generally in molecular diagnostics with any screening test that looks at very large information or large data. Any finding would be confirmed in an independent test, a separate independent test. This was not the case with PGT, so based on the initial result, we would decide whether to transfer that embryo or discard it. Now we have two independent methods confirming every single aneuploidy. To summarize the Pgt Ai, so we created it to remove subjectivity and improve accuracy. And with our new iteration, we've introduced paired end sequencing and SNP analysis to detect forms of aneuploidy that were previously undetectable. All of these changes have already shown some clinical impact, and we expect to see more and more with decreased miscarriages from previously undetectable forms of triploidy. I will now transition to endometrial receptivity testing for repeated implantation failure patients. I'm going to be brief with this. My colleague Steve will be talking about this tomorrow as well. So I've just shown that Pgt Ai increases live birth rates per embryo transfer. However, even when we know the embryo is euploid, it doesn't guarantee implantation, and the success rates are, far still from 100%. And there are many reasons why that could be, but one of the important factors could be, and there's literature to support this, endometrial receptivity. So the window of implantation is the period during which the endometrium is most receptive for embryo implantation. And in a textbook cycle, we're looking at days 19 to 21 of the menstrual cycle. In an ART cycle, this is typically after 5 days of progesterone administration. We also know that in up to 30% of women who have experienced repeated implantation failure, their window of implantation is displaced. And the majority of those patients are found to be pre-receptive, That's 25% of them, and 5% post-receptive. This is the way, the different types of results we can get using our test, which is a gene expression analysis based from endometrium biopsy. And if typically the biopsy would take place at the time of embryo transfer, but that's in a mock cycle. And if it is found receptive, then embryo transfer can happen at that time. This is the correct time of window of implantation. If the patient is found to be pre-receptive, that means she has a delayed window of implantation, and the optimum time for transfer is a day later. On the other hand, if she's found to be post-receptive, then she has an advanced window of implantation, and transfer should happen earlier. So this is just to illustrate the idea. A mock cycle needs to take place in order to do the embryo biopsy. So the mock cycle will mimic the frozen embryo transfer cycle exactly, but except instead of performing an embryo transfer, an endometrial biopsy would take place. If pre-receptive status is found, then precision embryo transfer can be done on P+6 rather than P+5. So who should ER, endometrial receptivity or ER testing, be offered to? So far, and I have to admit here, there's very limited data and few studies that have looked at this. The numbers are really small, but there is evidence supporting improvements in IVF outcomes for repeated recurrent implantation failures patients. So we're offering this for Pgt Ai patients who have had multiple failed euploid embryo transfers in the past, and also for patients who have had multiple failed transfers without Pgt Ai, although we would strongly recommend Pgt Ai first, as that could be the biggest cause of implantation failure. It can also be offered, or it's a good option, for patients that have just a single euploid embryo available for transfer, and it could be their last attempt at IVF, so making that transfer all the more precious. So optimizing the timing of transfer becomes more and more critical. So to conclude, Pgt Ai mitigates the effects of maternal age. There's very large data and many papers supporting these findings, and increases in live birth rates per embryo transfer, as well as reduction in miscarriage rates. And I'm happy to share a lot of those papers. I didn't focus this talk on that, but I'm happy to share a lot of those papers and discuss them with you. Whoever's interested, please reach out to me after this talk. Recent developments using artificial intelligence allow for more accurate Pgt Ai analysis, which has resulted in more confident single embryo transfers. And we're seeing more and more patients that have an euploid embryo available for transfer. Finally, endometrial receptivity testing combined with Pgt Ai improves IVF outcomes for repeated implantation failure, and may be a good option for other patients as well, if it's cost effective for them to have the test done. Thank you for your attention. I'm happy to take questions. No questions, all right. Thank you.
Thank you very much for explaining genomic testing in PGT so well. Our next speaker, the brain behind the event, is consultant obstetrician, gynecologist, and fertility specialist. She's a former member of RCOG's International Representative Committee for Pakistan, former vice president and executive member of SOGP, member of editorial board of Journal of Pakistan Medical Association, executive member and joint secretary of Aman, Association for Mother and Newborns. She conducts regular training workshops on infertility, colposcopy and cervical cancer screening, PPI-UCD, MVA, values clarification and attitude transformation in reproductive health and contraception. She has authored numerous articles in national and international journals and developed guidelines and training manuals. also practicing as a consultant obstetrician and gynecologist at OMI Hospital, and the clinical director of Concept in Pakistan. Please welcome Professor Sadiah Paul. Thank you.
Thank you, Maria. I just feel very embarrassed with that introduction because it makes me like a jack of all trades and master of none. But anyway, so here I am talking about a subject which is very often not talked about, even in Pakistan. We're quite ignorant as doctors about the laws as well as the religion. Because I prepared this talk at the request of Professor Arshad Chauhan. He's also an IVF expert. He's not here yet. And when he asked me to do this talk, I was very upset with him because I knew very little about it. But then I learned so much. So maybe you might benefit from this as well. So I will talk about first the religion pertaining, because we're basically a Muslim country and predominantly a Sunni Muslim country. And IVF was first practiced in the Sunni world, Muslim world, with clinics opening in the mid-1980s in Egypt, Saudi Arabia, Jordan, and all Sunni majority countries, including Pakistan. We have Professor Rashid Latif here, the pioneer of IVF in Pakistan, and within a few years, he had the first IVF baby in Pakistan, way back in 1984. Is that right, Dr. Rashid? 1984, yes? So this basically followed a fatwa from the Grand Sheikh of Egypt's Al-Azhar University. And this is the first widely authoritative fatwa on medically assisted reproduction in 1980. This fatwa was issued only 2 years after the birth of the first IVF baby in England, Louise Brown, as you all know. Very few people know this, because even our patients and doctors who refer clients for IVF, even now, they often say, "Ji, Dr. Sahab, ye theek hai, Islam ke hisab se sahi hai, hum koi galat kaam to nahi kar rahe." So basically what I said in Urdu was, they ask, are we doing something against Islam? Is this allowed? Is it, kosher or halal? And then those of us who are practicing IVF have to sort of go and give them like a mini lecture on it. And at the end of my talk, I will request Professor Rashid to relate the story of how he managed to do it. I've heard it from him, how he managed to convince our clerics that this is something which is not contrary to the religion. So this law was recently revisited in the Federal Shariat Court in Pakistan due to a case of surrogacy filed in 2015, and it went on till 2018 before the decision came through. And this was a case of a US-based doctor who had an IVF baby through a surrogate mother in Pakistan. And after the baby was born, and I believe it was a daughter, the surrogate mother refused to give it to the couple. She said, "No, this is my baby and I'm not giving it." So hence the couple went to court to get that baby, which was considered their own. Anyway, so this full bench headed by the Chief Justice heard it, Mr. Justice Riaz Ahmed Khan, and hearing the case relating to the test tube babies and its acceptance in Islam. So the judgment was that while development of babies can be carried out in an external environment, meaning IVF, but both the male and female used to conceive the baby will have to be married as per Islamic law. Donor gametes judgment, they cannot have test tube babies by getting support from third parties in the shape of a donor egg or sperm. All third party assistance for making test tube babies is not allowed in Islam. If both the partners are legitimately married to each other, then modern machines or medicines can be used to make babies. Further amendment has to be made to the Pakistan Penal Code. The suitable section of the law has to be added regarding the definition of surrogacy, the same to be declared as an offense punishable with imprisonment as well as fine. The couple who arranges a surrogate mother would be liable to punishment along with the surrogate and the doctor who conducts the surrogacy procedure. So, there is also punishment for the doctor who maintains the sperm bank or egg bank for using in future for donor insemination, meaning donor insemination, if it's for the husband, which we all do, it's fine, but not with the donor, which should include imprisonment and fine as well. Any doctor involved in the procedure of surrogacy shall lose his license. So it has been discussed in the Islamic Fiqh Academy in Jeddah, established by the OIC, which is the Organization of the Islamic Conference. It is considered which is considered the highest Islamic forum for resolving various modern issues. Everything is not in the Quran, you know. So, and science has obviously developed and advanced over the thousands of years. So now we come to gender selection. The law in Pakistan, it's legal. In a recently held meeting, the Council of Islamic Ideology allowed test tube babies under certain conditions. It maintained that gender selection was not prohibited in Islam and it can be done within the limits of the Sharia. IVF is permissible as long as the sperms and eggs belong to a married couple. So they further remark that it is an innovation, and if it is done within the parameters set by Islam, it's fine. So, and repeating that surrogacy and donation is not permissible. However, he urged the medical community to think morally and ethically and not make financial gains the sole prerogative. A consultant at a Lahore-based IVF center raised concern that most couples, even those who were not infertile, approached them for a male child. This is quite common in our culture. And there were concerns about this as well, that while the concept of IVF is catching up, a lot of people have shown interest in gender selection, and for all the wrong reasons, meaning not just to get a healthy child, but for basically sex selection. Globally, PGD is used for screening and diagnosis of genetic diseases, and in early embryo prior to implantation and pregnancy, as well as finding out the gender. The purpose is to cut down the chances of having a baby with a genetic disorders by offering screening. The court declared that if the sperm has been obtained again by the father and the egg from the mother, and the same has been fertilized in the test tube through medical process, and the embryo is then placed in the womb of the actual mother, in that case, the child would belong to the actual mother and father. In all other cases where a woman is arranged as a surrogate against the monetary consideration or some other reason, the whole procedure as well as the resulting birth is against Islamic injunctions. So that is about, that's all we have in Pakistan about any kind of regulation or law. The Shia sect of Islam, which is the second largest sect of Islam after the Sunnis, are far more liberal, and they have different leaders from the Sunni ones. Unlike Sunni Muslim scholars who are scripturally based in their thinking, Shiite religious authorities give precedence to a form of individual religious reasoning known as ijtihad. I think most of us in this room who are Pakistani or Muslim are familiar with this term. Ijtihad means you adapt and change with the times, but keeping yourself within the limits of Islam. So through the use of aql is your thinking, your intelligence, you apply your intelligence, and I mean, I could give you an example that there were no aeroplanes at the time when Islam came, and there were camels. Camels were used as transport. So hence, can you say that in this day and age, it's better to travel by camels or by using an aeroplane? So you have to use your common sense and your knowledge and your head, basically. So through the use of aql or intellectual reasoning, Shiite ulama have come to their own conclusions regarding gamete donation using ijtihad, ijtihad meaning the improvisation, and muta, which is a temporary marriage, followed by a fatwa given by the Imam Khamenei. So this practice was allowed in Iran way back in the early 80s. So it's not something new. Ijtihad has allowed flexibility and pragmatism towards the new technological scientific developments, including IVF, and a number of other new medical technologies, for example, contraception, organ transplants, transgender surgery. So this is about Shia Islam. And whatever is not allowed in Pakistan at the moment, including donor egg and donor sperm, is allowed by law and religion in neighboring Iran and other Muslim countries like Turkey and Tunisia, and I think Lebanon as well. Am I right, Souraya? Yeah, so they're far more progressive than we are. And not all of them are Shia, predominantly. I mean, they're also Sunni like us. So moving on from Islam, I just started reading and reading more, and then I came, because you see, we have three major religions which follow one book, and Christians, Jews, and Muslims. So Christians have really evolved, and I think they have a lot more ijtihad and common sense, perhaps, than us. Looking at the Jews, they seem to be more conservative, at least that's my perception. But when I went into it, I think they are the most liberal. In Jewish halakhic law, male rabbis, not female rabbis, male rabbis legislate on the appropriate use of IVF for their followers. Third-party donation of gametes, including sperm donation, is allowed, since Jewishness is seen to be conferred through the mother's side, not the father. Okay, you become a Jew, you're only born a Jew. You can't convert and become a Jew. I guess most of you knew that. But if your mother is Jewish, you will be a Jew. Doesn't matter who the father is. So this is particularly through the act of gestating and birthing the baby. The Jewish state is pro-natalist, with the state subsidizing up to 6 cycles of IVF or up to the birth of 2 IVF children for any given Jewish patient. Rabbis are permissive when it comes to single career women, as well as lesbian Jewish mothers conceiving children through ART. So that's very, very liberal, more than Muslims or Christians, I think. So they're okay with single mothers having babies. They're okay with lesbians having babies. Most conservative rabbis prefer the non-Jewish donor. So that makes a lot of sense, scientific sense. Sperm be used to prevent, non-Jewish donor sperm is preferred to prevent adultery between a Jewish man and a Jewish woman, and to prevent future genetic incest among the offspring of anonymous donors in this small intermarrying country. So I haven't got that on my slide, but they are happy to take sperms of Muslim, Palestinians, whoever, non-Jewish. It's in fact encouraged. Debates have revolved around whether surrogacy should be allowed for the infertile couples using single or married surrogates. Generally speaking, single Jewish women are preferred as surrogates, both to avoid the implications of adultery for married surrogates and to confer Jewishness through a Jewish woman's gestation of the fetus. So, I mean, when I first read this, I was blown away. Maybe it's not new for some of you, but it's really, really quite liberal, I think. So in UK, we heard this about HIFA. They are a regulatory body and one of the pioneers. That's where IVF started. And you have legislation for many things, including the number of embryos transferred, et cetera, et cetera. And Louise Brown is over 40 years old now, isn't she? In the US, we have ASRM, which is also giving guidelines. So apart from legislation which comes from, the legal body, but there is a professional body, and that's what we're trying to do with Professor Rashid Latif's help, that it's about time we should have our own guidelines in Pakistan as well. So similarly, in Australia, they have a similar system to UK and USA with the Fertility Society of Australia. And this is another hot topic. This hasn't been touched in Pakistan yet, the use of embryos in research. So there are many ethical issues which are related to infertility treatment, and we're having a session tomorrow to discuss this. So I will not go into it. So again, these are things we all need to think about when we go into this. So I will end here, because we often end up, once you have the baby, this is what you might end up hearing. Thank you.
Thank you very much, Dr. Sadiah. So I hope you have enjoyed a session that started with the history of IVF, and Dr. Sadiah has now left us to reflect on where we want to take IVF in pregnancy. I would like to ask Professor Dr. Rashid Latif Khan to end this session with his comments, please.
Bismillah ar-Rahman ar-Rahim. First of all, I must congratulate Sadiah for organizing this conference. And generally, it's difficult to get good speakers in our conferences. But this session proves that her effort has brought fruit. And all the 4 presentations covered ART, now ART, previously IVF, so comprehensively. It gave us the history of IVF, how it started, and then the difficulties of initiating it and the opposition to it, then latest technologies involved in improving success rate. Various methods have been discussed. I don't know whether any of them is definitely producing better results or not, but they are in use all over the world. I remember one story. I'm a storyteller. You know, controversies in obstetrics and gynecology. Its first conference was held in Paris, way back, I think, 25, 26 years ago. I attended that. In that, there was a debate. Those days, there used to be debate in this conference. Debate how to deal with repeated pregnancy loss. And those days, it was called abortion. And somebody for some treatment, other against the treatment. So somebody who came for against the treatment, he cited so many things. Scientifically, it's not correct unless proved that patient is progesterone deficient or there's this. There are 100 causes. We shouldn't be prescribing anything. Empirically, we should be treating. The other person, I remember he came from Turkey. He said, when I get a patient with 2 pregnancy losses, there was a long, long list. He prescribes antioxidants, vitamins, heparin, you name it, progesterone, everything. At the end of it, the results of both were same. So we should not pick up new technology just because somebody has written a paper. But definitely, once it's proved, we should make use of it, because in Pakistan, we are, I would say, in the learning phase, how to set up our IVF program and how to promote it, how to get better results. We have our own problems. So, Sadiah, then coming to rules and regulations. You know, when we had our first pregnancy test positive after IVF, it took us 5 years to get first test positive. We were so excited, we gave it in the press. After 9 months, first IVF baby will be born. And all the mullahs, you name them, they gave statement with their photograph in the newspaper. It is anti-Islamic and it should not be done in Pakistan. It's American influence and things like that. Unfortunately, we lost that pregnancy through ectopic. So that baby never came. It took us some time more to get second pregnancy. We kept quiet. When it came to term, then I picked up the old newspaper. All those who had given statements against IVF, I went to them, to their home, as a matter of fact. I asked them, how much IVF you know? Because those were the early days of IVF. Even physicians didn't know much about it. How much you know? They had no knowledge at all. So I coined a terminology. Those days, bypass cabbage was just introduced. And I said, if bypassing arterial block for saving life, and here we are bypassing, those Brown was born for block tubes. For block tubes, we bypass the tubes. It's the same thing. They all agreed. When the baby was born, all of them gave positive report, positive statements in favor of IVF. So one important thing for all of us, explain to your religious scholars what IVF is and how it is done. Nothing wrong with this. They have put this restriction, no third party. All right. We don't do third party, but still we are helping 80% couples. And that's more important. So again, I repeat, thank you all for traveling long distance, coming over and speaking to us. I've enjoyed it. The whole history of Edwards, Steptoe, and everything. I'm lucky. I met them all. I made friends with them. So it's history. And Then covering the latest technology, how endometrial scratching or various era and things like that, they can help. Yes, surely we are making progress. Thanks to those people who are doing research for our benefit. Thank you very much.
Thank you very much. So after enjoying this session on ART, I would now like the audience to please enjoy your lunch. We have got an hour's break, and we'd like to be back in this hall for our second plenary session at sharp 2 p.m. Thank you very much.
Thank you.